Great, I think we'll go ahead and get started. So good morning, good afternoon, good evening from wherever you're joining us from. A warm welcome on behalf of the Boost community and the World Health Organization to the 8th and final session of the COVID-19 Recovery for Immunization Programs Fellowship. Today's session will focus on comprehensive session size planning. Next slide. So before we get started, I wanted to go over some logistics for today's session. Again, if you'd like to listen to this session in French, please select the interpretation button in the meeting controls at the bottom of your screen. You should see a globe icon. We've also included step-by-step instructions on the screen and on how to access interpretation either through your computer or mobile device. Next slide. So during the session, you can engage in dialogue with your peers and session facilitators through the chat box. You can also use this forum to ask questions throughout the session. Once we get to the question and answer section, you may raise your hand to voice over your question if time permits. Finally, please do remember to rename yourself, so your first name, your family name, and country, so that we can record your attendance for today's session. Next slide. Today I'm joined by two session facilitators. So we have Suleiman Khan, who's the team lead of supply chain and logistics, and Daniel Briggen, who's the technical officer of supply chain guidance. And they're both working for the essential program on immunization at the World Health Organization. Next slide. In terms of today's agenda, we will first go over the submission of your strategic proposal or case study. We'll reflect on some key takeaways from session 7, and then we'll dive into the main topic for today's session, which is again on comprehensive size session planning. At the end of the session, we'll save some time for question and answer with the audience. So again, I do encourage you to share your questions in the chat throughout the presentation. We'll be recording them from our side and we'll be reading them out when we get to that section of the presentation. Next slide. I think now I'm going to turn to just a quick poll, and we want to see have you almost completed your strategic proposal or case study. So as a reminder, we sent that template a couple weeks ago. Again, we're going to go over the submission instructions in just a second, but if you could share kind of your progress so far, that would be great. And I'll give everyone just about 30 seconds. Great. I think either Aisha or MJ, could you maybe close the poll and share the results?
Yes, so the results are 38% have said yes and 62% have said no.
Okay, great. So I'm glad to hear that at least some of you have already started and hopefully others will catch up soon. So next slide, please. So now I want to go over the strategic proposal and case study submission portal. So as we mentioned the last couple of weeks, we've been preparing that portal. It is now live. So you are able to go on and start transferring whatever you've worked on so far into that portal for that final submission. Next slide. So just a note that we will be sharing all of these detailed instructions in both English and French following the session. We'll also record the session and pull out these brief instructions so that you have them whenever you're ready to start putting in your proposal. So the first step is to access the online submission portal, which we've provided a link to on the screen and via the chat as well. Very importantly, for our Francophone audience, if you'd like to view the form in French, it's important that you click on the tiny little globe icon at the upper right-hand corner of your screen. And I've actually pointed an arrow to where it is. It is quite small, but hopefully once you're on your own computer screen or mobile device, you'll be able to see it clearly on that upper right-hand corner of your screen. And then you just need to select French for the portal to be translated into French. Next slide. So once you log on to the online portal, you'll be asked to create an account. So to do that, you just need your email address and a password following some of the specifications that are listed on the screen. And then once you fill in those details, you'll automatically go to your profile and you'll be asked to fill out just a few basic fields, your first name, last name, email, etc. Once you filled out a profile, you're going to click on Get Started to fill in the actual details of your strategic proposal or case study. Again, the instructions are here. It'll make a lot more sense when you're going through the platform yourself. And like I said, we'll have these instructions available right after the session. Next slide. So just a few important notes as you go through the submission portal. We ask that you please read all the instructions very carefully. There's a lot of wording here. You should be familiar with all this language as it was pulled directly from the template that we shared out earlier. We ask that you answer all questions in the order on your screen. So please note when you select either French or English, you'll see different questions based on that selection. And that's the same with whether you choose track A or track B. So please make sure that you choose those tracks and languages before you proceed to the end of the template where you're actually asked to insert your answers. I do encourage that you save your work after completing each section. Again, I have an arrow on your screen that points to save draft. You could go up there and you can save as many times as you like. I just suggest after each session you save so you don't lose any of the work that you've done so far. We ask that you submit your proposal when it is complete, which is that Mark Complete button that you see on your screen. We do ask that you make sure that your proposal or case study is fully filled out before you do hit that button, as once you do that, you won't be able to go back in and edit your responses. Importantly, you can only submit one proposal. So we're only accepting one proposal per individual or team. I know we got a few questions around if you can submit as a team. That is okay, but you must choose one focal point and that person will fill out the form. So we won't be accepting multiple proposals with the same title from a team member. So just one proposal only per individual or team. Another very important note is that we have extended the deadline until Friday, July 8th. This is the only extension that we'll be making. So please be sure to start transferring your work over to the portal and submit before next Friday's deadline. Next slide. I think that's it from the submission portal. Of course, if you have any questions, put them in the chat and we'll get to them towards the end of the presentation. So I just want to go back to week 7, so last week, and the reflection question, which was on what from this presentation will help you advocate for financing within your government to implement COVID-19 recovery activities, and what information you'd like to have to follow up. So on the next slide, we showcase just a few of your responses. Kosi noted that the session helped him strengthen skills on how to negotiate the budget during the different stages of the budget dialogue, and especially to plan a budget accordingly to implement the zero-dose recovery activities. Mala said that she's always didn't really know what Gavi meant or what they did, but she's glad that she's able to expand her horizon on another level and is truly amazed by the coalition of Gavi, CEPI, and WHO and the formation of COVAX. And then Jean noted that the session helped him to argue his project in order to strengthen the improvement of catch-up vaccination and to make good vaccine management. A few follow-up information that would be helpful includes a document containing the procedures for requesting funding from Gavi, as well as the eligibility criteria. And we also had a request for additional graphics as well. Again, I encourage you to visit the Boost Learning group to post your own responses and to comment on your peers. Next slide. And with that, I'm going to hand things over to Laura, who's going to go over some other key takeaways from last week's session. Over to you, Laura.
Thanks, Liz. Hi, everybody. So last week's session, I think some of the information was new to many of you. So on the next slide, firstly, Joanna went through the National Immunization Strategy, which is called the NIS, the acronym, and it was formerly called the Comprehensive Multi-Year Plan. But this is a key strategy that most governments or most programs should have. And it's a 5-year long-term strategy that helps to strengthen immunization programs. And as part of the IA 2030, the Immunization 2030 that we've mentioned to you before, that having a good, strong NIS is key to successful implementation and impact of IA 2030. So this document really helps with the strategy, really ensures that you align and work towards the same goals as the national government. So I think that's kind of one of the key things we took away from what Joanna was presenting. So making sure that you're aware of what the key things are within the NIS can help you also align with some of the work that you're planning. In the next slide, we also heard from Natalie, who kind of went through 4 key elements for successfully negotiating a budget. So that went through how to know how much resources are available. So you have to be aware of really what is realistic and what your government has available to you. Also know how to cost your plan, and she went into detail about how to cost your plan. Also, it's important that you can demonstrate, what is they demonstrate the impact from the work that you're planning to do. So ensure that it's value for money. And then finally, demonstrate the good use of the budget. So show how the resources were spent, if they were spent well, and how they were spent efficiently. So I think that was a very key important thing that Natalie described during her presentation. And then finally, on the next slide, we have the summary from Gavi, which kind of went through some of the key success factors for advocating for your project and accessing funding. So they went through making sure that you have a strong proposal with the supporting narrative. And I think that was kind of a key thing that came through, is that you need to justify why you want to do this work, how it's going to be helpful to the government, and then also how to make sure that it aligns with some of the priorities that the country has. And that meant that you should know who to address, and also how to access funds and engage in trying to ensure that you can make your proposal be fully possible for implementation. So that's kind of some of the key takeaways. And I think the recordings are available and the slides from last week. And of course, there was some requests for some documents, but I'm sure if you look online, you can find many of those are available on the Gavi website. And also we had links from last week related to the NIS, and also some links that Natalie shared also during her presentation. So make sure that you make use of those if you want to find out more information. Okay, thank you.
Hi everyone, this is Dan Brigden. I believe it's over to me now to introduce this poll. And it's a simple question. Have you ever heard about effective vaccine management before? Have you heard about it, or is it completely new to you? Great. Well, it's looking like the answer is largely in the positive. Excellent. That's great, because now I'm going to be able to spend about 5 to 10 minutes talking to you about the EVM Effective Vaccine Management initiative. And then I'm going to talk a little bit more detail how EVM, some of the data that EVM collects relating to session size, that's relevant to session size planning. And then I'm going to hand over to my colleague, Solo Kone, who's going to be talking about that in more detail. Next slide, please. Okay, so EVM, Effective Vaccine Management. What is it? Well, it is a tool and process that sets a standard for the vaccine supply chain. It was founded in 2009, or it was launched in 2009, and since then it has been, national EVM assessments have been conducted over 160 times in just under 90 different countries. So next slide, please. But let's just, before we go into a little bit some of the technical details around EVM, I'd just like to sort of break down the EVM into 5 different pieces, because I think it would be worthwhile to understand some of the granularity here. Firstly, EVM, you recall, sets the standard for the vaccine supply chain. And how does it do that? Well, it defines just under 1,000 requirements, also known as standards, that taken together will define the optimal immunization supply chain in a country. And that is a huge, huge long list of requirements covering every aspect of the immunization supply chain. Secondly, because it's setting the standard and because it's a tool, it needs to be used to assess whether that standard has been met in a country. And that's where the second part comes in. It's also a questionnaire that can assess if a health facility meets those standards, every single one of those 950 something standards. So it's the set of standards, it's the questionnaire itself, but it's also the delivery mechanism to collect this data. So we have a mobile app that we use to administer the questionnaire, and that's available in all the different app stores. It's available for a free download. And if you're interested, you can type EVM Assessor into the Apple App Store or the Android Store or the Windows, the Microsoft Store, and you can download it yourself. The fourth part of EVM is the administrative side. It's the secure website that creates and manages EVM assessments, and it's used to give you all of the analysis and all the dashboards to understand where the supply chain is strong and where it requires improvement. Finally, EVM also provides an improvement planning tool that can be used to take the learnings that have been gathered by conducting this assessment and turning that into an improvement tool to develop a CIP from the assessment results. Next slide, please. So let's see how this all fits together into a single process. Because I mentioned that EVM supports the creation of a continuous improvement plan. And really that's its most important and critical function. So let's start at the beginning with the assessment. EVM is used to create an assessment, collect the data, and together it will assess the immunization supply chain of the country. And that is the assess part in the top left of the diagram that you see. Once the assessment has been completed, we will move on to creating the improvement plan and the continuous improvement plan that can be part of a wider EPI review. It can be part of the NIS. It can be part of wider improvement activities that go beyond the immunization supply chain. Once that plan has been created and signed off and budgeted, costed with timelines, we can move on to the next phase, which you could say is where the rubber hits the road, because it's where we implement the improvement plan. We conduct improvement interventions on the supply chain. And the fourth and final part is the monitoring, where we analyze what has happened during the implementation of our plan, whether it has been successful or not, and whatever happens, we will move on to completing this process again, because it's a continuous improvement process. It doesn't begin and end with an assessment or a plan. In EVM, this is something that takes between 3 to 5 years. So EVM starts with the assessment. It identifies the strengths and the weaknesses of the supply chain. It informs the plan for implementing the improvements, and it monitors ongoing performance. And the EVM tool is used to support this entire set of activities, this journey from the beginning to the end. Next slide. I'm showing you here a whole load of numbers, and they may be a little confusing, but this is perhaps the easiest way to understand the richness of the data that an EVM assessment can provide to decision makers at the national level. What we're looking at here is a matrix that we call a heat map, because the scores under 50 are shown in red. Those between 50 and 80 are shown in yellow, and those above 80 or above are shown in green. And the column on the left-hand side defines the EVM criteria. And if you're familiar with EVM1, you'll know that in this EVM2 analysis, the criteria are largely the same, although there are 4 new criteria. This is used to assess the facility operations, the health facility operations, E1 to 9, and the health facility management, M1 to M4. So all of those values can give you a score for a single health facility, or it can give you a score for an entire immunization supply chain in a country. the same graphic can be used for any level of aggregation. So I've explained the column, and that's the scores on the right-hand side. But what about the columns in the middle, C1 to C6? Well, this is where EVM shows its improvement in EVM2 over EVM1, because it provides a much richer level of analysis, not just understanding the facility operations in, let's say, facility infrastructure or equipment, or maintenance and repair, or waste management, or vaccine management, but also around the inputs, what is necessary for the health facility to be successful in conducting its immunization operations. C1 is the infrastructure, which is typically the building that is necessary to conduct the immunization activities. C2 would be the equipment, which might be a fridge, might be a freezer. C3, the information technology needs, etc., etc. So in looking at this graph, we can make a very, very detailed analysis of the comparative strengths and weaknesses of from one facility to the entire national perspective of the supply chain. And underneath every single one of these numbers, you will find a list of requirements. I referred to them earlier as the standards of EVM, these 1,000 or so standards. So next slide, please. Here we have a similar graph, but I illustrate here the way in which a single facility can have this graph, but it could be also applied to 45 health facilities. In this example, this is the aggregated scores of 45 health facilities. I hope you're already beginning to see that we have a detailed analysis here that is already pointing the way to how where improvements need to be made, and how we can take this analysis and we can move it to an improvement plan. But before we do and we continue this analysis, we can use any number of filters on the left-hand side here. This is a screenshot from the EVM website, but you can see how we can apply different filters here. For example, if we are interested only in health clinics that provide immunization services, we can filter the supply chain to only include an analysis of those. If we only care about the national store, we can filter only by that view as well. We can also filter geographically and understand scores from health facilities in a part of the country only. And there are many other analyses that are possible here, but I don't have the time to go into them fully now. Next slide, please. Let's move on a bit and let's sort of focus more on what this webinar is focusing on. And let's look at the information collected by EVM that relates to immunization session planning. Well, before we get there, let's just understand the way that an EVM assessment is conducted. Before the national assessment can be created and delivered, the setup for the country needs to be completed. And as part of that, the national vaccine schedule needs to be entered. Now, this is not just giving generic vaccine names like BCG. This would be giving the exact vaccine products that are used within the national schedule. That may be more than one type of presentation for the same vaccine, or more than one type of doses, or more than one commercial product. They all need to be entered if they are used. And typically in EVM, if the vaccine is a PQS pre-qualified vaccine, by entering 6 values, the vaccine name, the manufacturer, the commercial name, the formulation, the presentation, and the doses per primary container, that is enough to uniquely identify the vaccine product, and all of the other information such as storage capacity, diluent storage capacity, etc., etc. All of that information can be automatically pulled from the PQS database in order to conduct further analyses that are required. If it is a generic vaccine, the information that you see on the bottom left half of the screen under vaccine details must be entered manually. But if it's PQS pre-qualified, only the top 6. Next slide, please. So at this point in the country setup, we know all of the vaccines that are used in the national schedule, and we can make an analysis of their storage requirements at each level of the supply chain. But we need to know more than that. We need to know for each vaccine product, country-specific information. We need to know these four key pieces of information. We need to know the target group, which is the percentage of the total population that will receive the vaccine. Maybe it's the birth rate, for example. We also need to know the predicted wastage rate for the vaccine, for example, 5%. We need to know the number of doses per recipient that each recipient will receive. Maybe it's less than one if it's fractional dose, but otherwise it will be a number greater than that. And finally, we need to know the coverage rate. This is the target vaccination coverage rate. For example, it might be 90% for the country. Next slide, please. So in EVM now, for every country that has conducted an EVM assessment, we already have quite a rich understanding of what's required here, and we can begin to build up a picture of likely wastage or optimal session size planning. But before we move to that, let's look at what are the questions that EVM ask at each facility relating to this. There are two questions that are both relating to the frequency of the vaccination sessions that are offered. The first is the frequency of vaccination at fixed site, and that's the number of days in an average month during which the vaccine is administered through immunization sessions. The second is exactly the same question, but for outreach immunization services, the number of days in a typical month during which the vaccine is administered through outreach sessions. Next slide. And I include here a screenshot of how it looks like in our mobile application, so you can get an idea of how the data is collected. You would simply enter the number for each facility and for each vaccine, and you would move on. So you can see once we have completed this national EVM assessment, we are in command of an extremely large amount of data that could be very useful in session size planning. And that's the end of my my little presentation. But before I finish and hand over to my colleague Solo, I just say that if my brief introduction to EVM has been interesting to you, and you want to know more, you may be interested in watching some of the recordings of the TechNet 21 webinar series on EVM that just finished. There are 4 sessions starting from what is EVM to how do I conduct an EVM assessment to how do I conduct a continuous improvement plan, all the way to what information does EVM tell us about global immunization supply chain challenges. So I'll put the direct link to the recordings in this chat shortly after I finish. And if you're interested, you're very welcome to review that information. So perhaps I stop here and I pass over to Solo. Thank you very much.
Thank you so much, Dan. And next slide. Yeah, okay. Dan has presented the EVM. This is just a brief introduction, and okay, and then see how do we through the EVM assessment we can collect the data on the implementation of vaccination sessions and compare with the national guidance, or sorry, I haven't put it here. And then compare with the national policy or instructions from those. Yeah. Next slide. So just to present the session planning, you know that I start from the RED strategy, which is the reaching every district that was initiated earlier 2000 years till 2005. And then it just provided the sessions plan as an essential tool for that strategy implementation, and where it establishes for each facility the frequencies are part of this tool just to present and to display at the facility, establishing the frequencies of vaccination sessions for the public and for communicating to the population and the communities also. And this should be supported by the objective of reaching the high and equitable coverage, this session plan, because that's the purpose, and also keeping the vaccine demand, the vaccine consumption at a minimal or optimal level. Knowing that it should be able to be delivered by the workforce that is at each facility. And here the principles are that the population will show up based on this session plan that is communicated to them through different communication means. And the second principle is that any eligible target that present at the session will have received the eligible vaccine for that session. Next slide. When we move, the guidance got improved, and we had the IIP, the immunization in practice, also get some guidance in a very big, beautiful guidance document that was issued. I put here some extract for your communication. And in this IIP, the session plan include the aid for the facility, for each facility, the list of communities that are deserved by the facility, the distances to the health center, the total population, of course, and then the type of sessions that is covered, that's covering each community. And this can be fixed or outreach, depending on if it is rural communities. This is usually depending on the distance to the health facilities. And for urban communities, this may depend on other factors like not distance necessarily, but social factors or convenience of the target groups that are being served by the community. And here the frequency of the session will depend on the number of infants expected at each session. And this is defined by the total number of population, that the catchment population of the community. Next slide. Here, the IIP tried to provide an indicative session frequencies by population size ranges. And this is based on the number of vaccinators available for each session. And you realize that the key principle for establishing those frequencies for that 30 infants per vaccinator session was an estimated workload during the IIP, and also this amount, this number of 30 infants to be vaccinated per session as acceptable workload may vary depending on national immunization schedule. If you have more vaccines, of course, it will be adjusted, and the national immunization policies and strategies in place. And based on that, this figure is showing different population ranges, and showing that, for example, that for a population of 3,000, was an estimate that if you have 2 vaccinators, the frequency could be just 2 weeks, every 2 weeks. If it is just 1 vaccinator, you increase the frequency by making weekly. And then if you have 3,000 population for 2,000, and you have 1 or 2 vaccinators at the facility, the session frequencies with around 1 month. And for a smaller health facilities, definitely the frequency is in the range of quarterly vaccinations. This was, as you can see here, these are really broader ranges of population, catchment populations that are giving indicative frequencies for each program just to adapt to their specific conditions. Next. So we have now the pool question. At the end of, as you can see, at the end of an immunization session, a mother requests that her 14-month-old child is to receive 1 dose of measles vaccine. You have an open measles vaccine. What will you do? And you have three possible answer, four possible answer here. Will you tell the mother to return and to next day? Will you open the vial and immunize the child? Or will you recommend that the mother take the child to another health center? So I think here, interesting, most of you will still vaccinate the child, which I think it is most in line with the session plan principles, and also putting the emphasis of protecting the child instead of just saving the vaccine, we will assume. Those who are put just next day, maybe they have different specific reasons here. Maybe we can just elaborate maybe later on. But I think this is really interesting that the maximum is just going for administering the vaccine dose. None of the above. Interesting. What then in that case you will say? I think we have 53 participants out of % of the participants has answered to the questions. So great. So most of you will just decide just to administer to immunize the child instead of reporting or deferring to another site. Thank you. Next. So there are challenges. You see that despite of most of you have decided that you will still vaccinate the child. You see that there are a couple of issues with the immunization session planning based on the IAP the guidance. As you can see that the frequencies are established regardless of the vaccine characteristics. So number of the vial size or the status of multi-dose vial policy. This policy, just to remind for those who may have not reminded this, is that this policy allows a specific multi-dose vial to be opened and reused in subsequent sessions. So you can get save for the vaccines. So this is lacking in the guidance in the IIP. And then therefore, the wastage have become rapidly an issue during the implementation of the sessions. And then I think that each of you may have a personal experiences see on the field that matter being at the session waiting for the quota to be reached for specific vaccines, the number of mothers to be or kids to be available, let's say, before one vial can be opened. So these are some of the issues that are impeding the performance of the immunization as such. So here we say that the fear of high wastage has remained a disruptive factor for the immunization here. And some intuitive measures have been implemented by health workers to minimize this wastage, and this often at the expense of the vaccination. The second here is that the national level instructions regarding the session and established wastage threshold, session frequencies and wastage that have been stated are contradictable have been challenged by each specific service delivery context, because you say, okay, our policy is just to vaccinate daily. This may be applicable for large urban facilities, but you will have challenges at the rural health facilities where this instruction is difficult to apply. So therefore, we think that knowing the impact, which is the anticipated vaccine wastage in advance in the session planning, knowing that impact, what will be the anticipated wastage, will probably be a useful element that will remove this fear of vaccinating or opening the vial. And in this regard, WHO, we have been working on the session planning tool to provide an evidence-based planning of session, just to be able to set in advance for each health facility what is my anticipated wastage if I plan that particular option of session frequency? Once a week, twice daily, twice a week, monthly. What will be my wastage? If you have this in advance, then you can just smoothly and serenely implementing your session plan. I'm going now to share with you, next slide, this tool actually, by giving some snapshot of how to use it, and it will be probably communicated, sent you by the secretariat here, just to play with and just to try to use in your specific context. Next slide. First of all, the tool is just an Excel-based tool that is designed to define the most suitable vaccination session frequency from vaccine wastage and demand output. So it's just a simulation, you make a modeling. And the scope is just to conduct those assessment of the impact of different vaccination session frequencies options to determine the anticipated vaccine wastage, vaccine need forecast, and safety stock level, which is sometimes also a missing link. And the second purpose is to provide simulations for changing service delivery parameters and vaccine characteristic. What if I am using single dose vial? If I'm using 10 dose vial, if I'm just applying me to dose vial equals or not. So all these simulations can be conducted to get a sense and output that will just guide your decision. The applicability, of course, is just session planning, it will support that. A district micro planning where you have multiple facility coming at the district level to do that, and vaccine forecasting itself. Now, what are the principles that we apply for this? Is that first, so the session plan is established for each individual vaccine rather than making all vaccines will be one frequency. So each vaccine have to be analyzed separately. And also it based on the impact of, as we say, the vaccine demand and wastage are considered for selecting the most suitable frequency. On the right box, you will see that what are the key vaccine input that are required to be put in the tool just to get your desired output. These are mainly the number of doses per target. I think Dan has said it, exactly the same parameters. Vial size, number of primary container, the status regarding the multi-dose vial policy, and whether the vaccine can be, the open vial can be discarded or reused during multiple sessions up to 4 weeks. Next slide. So we have put in this slide a few examples of different session frequencies, comparing with a standard or we say the traditional estimation method. Say that a facility with annual target population of 347, target coverage of 90 for a vaccine for 1 dose per target, wastage 50%. A session we don't know yet because the national level will just state that, and you haven't yet established your sessions. Vial size 20 dose, and if you estimate the need, it will be just for 640 annual needs. If now you try to put forward your facility, planning for weekly sessions, twice a week, or daily sessions, you can see in the estimation row, the annual estimation row, how you will have escalating the vaccine demand, the number of doses that will be required to implement those session frequency you'll be selecting. And you can rank here for 1.5 times the initial 640 doses annual need to 7.6 times vaccine will be required depending on the frequency you'll be selecting. So we have changed at the bottom 3 rows. Even if you change the wastage, and it's a wastage here, you see that definitely the more you are providing the session, you will have more vaccine demand at the end. So this had to be known, and then the supply adjusted accordingly. So the national level cannot just say that, okay, implement the vaccinations daily if you are not receiving subsequent the supplies accordingly. Next slide. This also is showing that the same example, but applying now a vaccine that can be reused, where you have multi-dose vial policy that can be applied, but differently. You have at the bottom, you can see that 2 weeks reuse, 3 weeks reuse, and reuse up to 4 weeks, because many countries are still hesitant to fully implement the multi-dose vial policy. So here we are showing that this hesitance is not relevant, because if it is up to 4 weeks, just apply that, because you are making a lot of savings on the vaccine. As you can see here in the table, the same frequencies. You can see that again, the differences will increase or more or less the same for the standard situation in the yellow cells highlighted. But if we are using the multi-dose, applying the multi-dose vial policy fully, 4 weeks utilization, for example, you see that you will just decrease your vaccine consumption, your vaccine needs. So that's it works. So having such an outcome and a table, you can make a decision rapidly to say that, okay, I'm going to make weekly sessions. Once you establish that, then you stick to it, because you know already the impact on your wastage. Or even if you decide to make daily sessions, no matter the vaccine demand, you will stick to it, because you know in advance that what will be your vaccine demand or your subsequent wastage. So you don't need anymore to be afraid of wasting the vaccine, because you know more or less what will be the range of those impact. Next slide. So here we are just showing screenshot, mainly the screenshot of the tool. When you will receive it from the Secretariat, you will see that you start by putting the vaccine schedule here. I'm not going just to establish here. You select the vaccine in the yellow columns, different vaccine you are maybe using, including routine and supplementary also. You can apply this also for COVID or for a measles campaign for a facility. Next slide. And then for the district or the province, national level may be not relevant here. You plot for the district, especially because you have been planning for district micro plan. The district would have list here all the facilities in the column structure and the type of facilities, their catchment population, and possible the distance to the supply to the district level. So you have those information put up front. Next slide. And then during the workshop now, you start putting, you see the same figures, the same facilities are here. And in the yellow cells, for each vaccine in the schedule, you have to put the number of sessions as indicated by the national policy or the instructions. They say BCG is just once a week, BOPV is 6 days a week, etc., etc., etc. You put there. Next slide. And then you have now, this is the simulator. This sheet, you will see that it is the simulator where you have a broader sense of different options. The yellow cells are that where you can just select from or enter alternative figures for the population. For example, you see that this facility that is selected here, this service point, the annual target is 265, but the yellow cells on the right, you can change the figures of the population, the number of doses next, the target coverage. The multi-dose value policy is coming here automatically as 4 weeks, but you can change it. And then the vaccine that is selected is TD. You can select also. Once you put this here, you select now your frequencies in the yellow that put here weekly, whatever figure you can put here, and then it will calculate you, first of all, the distribution or the pattern of the number of doses to be administered per session, depending on the frequency. This small chart is showing that. And at the bottom, you will see that the impact on the wastage. You see that the wastage increases from daily, 1 day a week to 5 days a week. You will increase it. And next slide. And these are just showing a zooming on specific input data, again explaining, and output data just for comparison of these output to make a decision to support your decision on definitely what session frequency I'm going to establish for my program. Next slide. The same for the wastage. At the bottom, just it continues. For the bottom, you will see that the wastage will be calculated. The first small table is showing for open vial, and then the last is just the total wastage, including closed vial wastage that are factored in here. And these wastage that are calculated then will serve as benchmark for monitoring your vaccinations, your vaccine consumption and wastage. Next slide. Finally, once you have agreed, you have established a particular session that is suitable for you, this table will be generated by the table where you have for this particular facility here, you have all the vaccines, the target groups, the number of surviving event or the target for each vaccine, doses in the schedule, and the session frequency per week. Here you see that BCG is once a week, and this is 6 times. And then it calculates now for your mean session size, your anticipated wastage, and your vaccine demand, your vaccine need, and safety stock. If you have information on the vaccine prices or the cost, it will just calculate how much this session plan will cost for you, including we have put here for COVID, for example. So you have this sheet will summarize your session plan and its cost in terms of vaccines. Next slide. I think this is just the end. We have proposed here just a small exercise for maybe the secretary will share with you. Just to read, plot your figures, and then simulate what will be in this case the session frequency you may consider, and why you are considering this, why you are selecting that frequency and not another, and then discuss within your district team or your colleagues just to get the sense of the tool. I think that's all from me. Back to you, Laura.
Thank you, Solo. That's great. And also thanks to Dan. There's been a lot of discussions and questions in the chat. And I think, Dan, I'm happy to report that a lot of people are expressing that they followed EVM through Technic 21. And also some people have said they actually carried out the training in person. So I think that's showing that certainly EVM is getting great recognition in the chat amongst these participants. So one question I think I'd like to ask, I'll put this to you, Dan, is someone has asked, how is the EVM reading done? And in the slide you showed different colors in those figures, and they want to know what the meaning is behind those red, yellow, and green colors.
Sure, thanks, Laura. Both good questions. The first one, I suppose, having just completed the webinar series, I think the best thing to do is to recommend watching the webinar, the second webinar in the series about planning and delivering an EVM assessment, because if you want to know what it looks like in reality, and also what it takes to conduct an EVM assessment, that's the best place to start, because that's who, when, how. It doesn't go into how much money, but it certainly does provide more of a detailed understanding of how you do an assessment. So please check out that second one. If you're completely new to EVM, maybe watch the first one as well, because that's giving you a better understanding of the sort of why would you bother? What's the value? How does it fit in? What's the connection with other improvement activities? So definitely those first two. And I think the question regarding the red, yellow, and green is a really good one on the heat map, also known as a matrix. It's quite simple. The idea of this heat map is to show you very clearly in a visual way where the supply chain is weak and where it is strong, or where the facility operations and facility management is weak and where it's strong. And the red is where this area indicates an area of low performance because it is less than 50%. And the amber, like a traffic light, the amber is between 50 and 79, and 80 plus, which is the EVM benchmark of an optimal supply chain system of 80%, is shown in green, meaning that's a strong and well-performing component of the immunization supply chain. So that's the meaning of those colors. And as I mentioned before, what is underneath those colors, or those numbers that are colored, is the much more detailed information, the much richer and valuable information of what requirements are scored underneath that to give it that single score. So if you have a score of, I don't know, let's say 50% in your SOPs for temperature management, you want to know, how did I get such a low score? Well, you will click it and it will tell you the 5-10 requirements that EVM says you need to have in an optimal supply chain, and it will tell you the score for each of those. And it will maybe tell you something about your SOPs or your temperature management that you didn't know. And armed with that information, you will then be able to create your improvement plan and start creating activities that are going to address those shortcomings.
Thanks, Dan. That's really helpful. Someone also asked, and just to make you aware that Dan has put a link to all these EVM webinars that have been done, and also he's been great in putting other links to trainings and the resources that are available. But Dan, you mentioned PQS during your presentation, and someone wanted to know what that was.
Yes, sure. So PQS stands for Performance, Quality and Safety, and it's a department within WHO that is responsible for testing and validating, in this context, cold chain equipment and other sort of immunization delivery devices, and also vaccines as well. So PQS is, I suppose you could call it a stamp of approval, or a recommendation that minimal quality verification has been done, and therefore the PQS, if you visit the PQS website, and perhaps someone or myself can put a link in the chat, it can be highly useful to immunization programs to ensure that if they're looking to make purchases of cold chain equipment or vaccines or other products like that, that they make a purchase that is endorsed or at least past minimum validation by WHO. So if you visit the website, you'll see a list of fridges, you'll see a list of vaccines, you'll see a list of temperature monitoring devices, delivery devices, etc., or that have all passed this PQS test.
Great, thanks, Dan. So Solo, I have a question for you, and it's something that we have discussed before on numerous occasions. When we started talking about wastage, a lot of people had a lot of things to say about wastage, and I think the question that we posed, we saw that there was mixed responses in terms of some people saying, either no need to open the vial, while others were saying that the cost of that child's health is far greater than the cost of hospitalization or illness, which is exactly the point we're trying to get across. And just to mention that we discussed this before when we talked about reducing missed opportunities for vaccination, and I think this particular subject really encompasses catch-up vaccination, reducing missed opportunities and ensuring that we vaccinate every opportunity. So Solo, I think a lot of people have been mentioning in the chat about the best way to approach wastage, how do we account for cold chain and storage and these type of comments, and you know, using smaller dose vials as a way to overcome wastage. So it'd be great to hear what you think about that, and just general experience with dealing with wastage in the field and how to best address that and reduce, you know, any missed opportunities, but also help reduce wastage. Or we could discuss, you know, using utilization rate instead of wastage rate, but up to you.
Yeah, thank you, Laura. And these are really great questions. And there's really not a single answer because they depend on different contexts. First of all, I think wastage is just, we have to distinguish two types, you know, the wastage in closed vial wastage. So these are the vaccines that have been lost without being even presented at the session, you know, due to inefficiencies of the supply chain. What Dan has said now, you don't apply the early expiry phase out. You got VVM exposed. Then you have to decide. You got vaccines, phase sensitive vaccine exposed to freezing, etc., etc. Or you have received more vaccine than you can consume, and this vaccine got expired. So these are the wastage that we should avoid. The second type of the wastage, sorry, I just mentioned that. Sorry because I could not activate my camera when I was presenting because the bottom, I don't know what had happened. So you can see now how Solo has become for those who knew me. So the second type of wastage is just the wastage that are occurring at the service delivery when you open the vials. And then the question is always, do you go for a single dose or do you go for multi-dose? Laura, I think Laura has said, if you are single dose, you don't need to even fear, and then you don't need to make any calculation. You can just implement vaccination by the go. Supermarket, everyone to come. If you had a workforce, of course, you just pick a vial and then you vaccinate that child, because there's no additional organization just to make sure that the vaccine you have received will not be sufficient. But this has a problem because single dose presentation, you know, that occupy more vaccine cold chain. I think someone has said that rightly said that in the chat. So you should have the capacity to store those single dose vials. You see, you have to balance. And for multi-dose vial, yes, for that to minimize the wastage, you need to organize. Laura, you make this work on the reducing missed opportunities. And I think that the principle that should apply is that plan your sessions and implement your sessions as your plan. You can just adjust a few deviations, but you plan the session with a, let's say, 20-dose vial. Mothers come, even one person come, you should open it because it is already in your plan. You should not start saying again, replanning in the plan, because you know the impact already. So if you plan with a multi-dose vial weekly sessions, the first person the first child arrive at the session, just open the multi-dose vial. And the last child that will come, even if there's no more open vial, open a new one, because you know statistically you will get there in your planning outcomes. Now, but the benefits of that is that you have less cold chain space, then you can store other product and then integration. So you see, it is really a very difficult, no, you have to balance everything. But again, the principle that plan what you are doing and do what you have planned, not just send the mothers back because they are wasting time. Don't let the mothers wait during the day of the session because you want to save the vaccines. So this is what I can say. But so it doesn't mean that you have to vaccinate anyone who is passing in the health center, just catch him and then go and vaccinate. No, because the planning involved, the immunization involved resources. First of all, you may not have people just to do that. So at least try to respect that during your plan sessions. Over.
Great, thank you, Solo. And I hope everybody kind of recognizes that, this particular session, it links very closely with the beginning of the fellowship. Seems like a long time ago now, but where we discussed capture vaccination strategies, missed opportunities, and then we also discussed about the data session about understanding your catchment area. And I think that really is an important aspect of this. Is understanding what is the catchment population in your area, and then adjusting your session sizes accordingly. Because what we do know is that in many countries, as Solo has mentioned, people come for immunization sessions, they wait many hours because health workers are trying to have a quorum before they open up a vial, when really we should be having, allowing people to experience a good immunization session or good access to our services, whereby they come, they receive what they want. It also links to the demand presentation that Lisa made. We want people to have a good service delivery experience, but we know that many mothers have to wait sometimes 3-4 hours before they finish an immunization session. So I think this links all well together so that we can try and help and improve how we deliver immunization and ensure that people get what they're coming for. So I'm going to pass over to Jill Mill now.
Yes, hello. So there were some questions that related to EVM again, Dan. So you have a lot of experience in conducting EVMs, and there was a question asking how many countries are implementing electronic EVM in Africa. I don't know if you have the statistics offhand. And also, can you share the challenges?
Yes, certainly. I replied in the chat that I think something, just the number of EVM assessments conducted in the Afro region is something just under 100. But it's important to note that when we say electronic EVM, it's not quite right, because there are only two types of EVM. The EVM1 and EVM2. EVM1 was launched in 2009 and was retired in 2020. And EVM2 was launched in 2019 and is still going strong. The difference between the two is that EVM1 was primarily based on Microsoft Excel for data collection. Although there was a website that provided some analysis, it was primarily an Excel-based tool, and it proved to be extremely successful. EVM2 takes advantage of improvements in technology, mobile technology and web technology in particular, to make the analysis component of EVM much stronger, and hopefully the data collection component easier and simpler to conduct, because nowadays it's absolutely standard. It even sort of would be unexpected if anything other than a mobile app was used to collect data in the field for such a sort of comprehensive analysis. So that's the difference between the two. So you could say that they were all electronic. EVMs in Africa have been extremely successful in helping to improve supply chains, develop improvement plans, etc. Regarding the challenges, well, I think there are of course many challenges for EVM, and that's why I would recommend watching the webinars that we've just completed, because they really talk about the issues of how you do this, the problems you might face. I think, to speak in very general terms, I would say there's two types of challenge. The first is the sort of just making it happen, which involves getting buy-in or approval or engagement from all of the stakeholders in the improvement plan. And that means you don't do an EVM assessment until you have the Ministry of Health and other key decision makers on side and supportive of the entire activity from the beginning, which is the EVM assessment, to the end, which is having completed the improvement plan. Now, because if you don't have Ministry of Health and funding partners and other partners, other national partners engaged, then it's unlikely that an improvement plan is going to be successful. It's more likely it will be written by someone and then will end up in a drawer and never see the light of day. So I think that's the first challenge that needs to be addressed. The other challenges are more simpler to resolve, like, for example, do you have the funding? Because to conduct an EVM assessment, you need to ask yourself how ambitious you want to be with that EVM assessment. You can assess a small fraction of your health facilities in the country, let's say maybe 20 facilities, but still to assess those 20, you must train your assessors, and then you must have human resources to manage this assessment process. But these are all logistical issues that are relatively simple. With the will and funding, that they can be met fairly quickly. I think for me, the biggest challenge is to ensure that all the decision makers, i.e. Ministry of Health, are fully supportive of the entire initiative. Maybe perhaps others like such as Solo may wish to add something.
No, Dan, I think you have covered it.
Okay, thanks. That was very helpful. And so one person has asked about templates. And so you did show Solo and Dan some forms and templates. So where could one go for all these different resources?
I think, Dan, maybe you will be sharing also the link to to the TechNet and the essential our supply chain website, where all these tools and guidance materials, both EVM and wastage calculator are posted.
Yes, I'll put that in the chat very shortly. And I've also put the links to the EVM website in the chat. You can find that. And if you wish to get involved and create an account for yourself and even assess a health facility, perhaps you want to see what the EVM requirements are or what standards EVM sets for the supply chain, you can create an account, create an assessment, and then assess the facility. But the first step is to create an account, and for that you must request access. Go to the website, and I think it's on the app page. It explains in more detail, but essentially, in a nutshell, you send an email to EVM admin, and then once that email is received, your account will be created.
Great, thanks, Dan. And Solo, back to you. There's a question here asking about how the session frequencies are a factor that affects vaccine wastage, and how that plays out when you have vaccines that have to be discarded after reconstitution. So I suppose it's trying to understand, for many vaccines, we have to reconstitute them before we use them, and often they have to be used within a certain time period. So how does session frequency affect that, and what can be done to try and reduce, I suppose, the risk of increased wastage with a reconstituted vaccine?
Thank you, Laura. I think this is the core principle of the session planner. The session frequency determines the mean session size for a given population to be vaccinated. If you are 1,000 kids annually to be vaccinated, and you are reaching all of them, let's say, the session frequency will determine, you have to divide by the number of sessions, isn't it? So session frequency, you have, let's say you have weekly sessions and you have 48 weeks in the year, knowing that you will have 4 weeks holidays or leave, something like that. So you will have per session the number of kids that are anticipated to arrive statistically in average. So knowing this number and knowing the vaccine vial size, you can calculate what will be the wastage for each session. And this is it. Where it become a bit complicated, and then I think your question is about that. When you are reusing a multi-dose, you are reusing open vial for subsequent session. Then you adjust the total number of the session effective. We call it effective session. I think by end of the, Maricel is not there. I don't know where we are publishing a document just that will guide that. You adjust the total number of sessions. Let's say you have weekly sessions, you have your 48 weeks. To get the effective sessions with multi-dose vial of 4 weeks, you divide the 48 by the number of weeks. The number of weeks you can reuse a vial. Say, let's say you have 4 weeks. So 48 divided by 4, you will get 12. So mean that effective sessions for that particular vaccine will be 12 sessions during the year. You got what I mean? From 48, you will get now only 12 sessions. And then now you divide now the total population, the target population by the 12 to get the average number of doses you are going to administer. Once you have that figure, the same, you calculate the wastage rate based on if you are using 10-dose vial, 2-dose vial, 20-dose vial. Is that clear?
Very clear. Thank you, Solo. That's great. And I think this is, hopefully everybody, you recognize that this is a very practical session and it applies really to a lot of things that we've covered throughout this fellowship. So I want to say a huge thank you to Dan and Solo for providing us with this really clear overview. And we have a reflection question for this week's session. Liz, if you want to share that.
Great. Thanks, Laura. And also just wanted to ditto your thanks to both Solo and Dan for their excellent presentations today. So in a moment, we will show, I think first, before going into the reflection question, I just wanted to go over the submission guidelines one more time for those that are just joining us a bit later in the session. So again, you can access the online submission portal with the link that we'll be sharing in the chat box. Again, we're going to also be sharing this link via email. We'll post it to the Telegram channel. We'll post it to the Boost Learning group so that you will have access to the website. Again, we will only be accepting proposal and case study submissions through the online portal. So please do not try to email us your template or any other items. We will not be processing or reviewing those proposals via email. So you must submit it through the online portal. Again, if you are a Francophone user, you can access the website in French by clicking on that globe icon and indicating that you'd like to complete the template in French on the form itself. Next slide. Again, just a few instructions. You will have to sign up for a user account. It's quite simple. You just need your email address and a password and following the specifications for the password that's listed on the screen. Once you log in, you'll fill out a brief profile, and then you'll be able to access the proposal and case study template where you will fill in all the details of your submission. Next slide. Again, just some very important reminders to please read all the instructions very carefully, to answer the questions in the order on your screen. So when you select track A or B, you'll be seeing a different set of corresponding questions. So make sure that you select the track before you proceed on in the form. Again, be sure to save your work after completing each section so that you do not lose your work. We ask that you only submit one proposal. We will only review one proposal from each individual, or if you decide to submit as a team, we'll only be reviewing one proposal per team. And again, the new deadline and the final deadline for submissions will be Friday, July 8th. So we're giving you a few extra days. So we do encourage you to log on as soon as you can to start filling out your proposal template in order to submit. And then I think just to go back to the reflection question for today's session, again, this will be posted in the forum section of the Boost Learning Group. And we're asking you all to share what from today's session will help you improve an immunization session. Next slide. And just again, a reminder to be sure to submit your proposal by July 8th. Next slide. And then as always, we do have a post-session survey that we ask you to complete. Again, have links again to the Boost Learning Group and Fellowship Telegram channel, which I know many of you have already taken advantage of. And then last but not least, and we'll also be circulating this link, we have a post-live engagement series survey. So just to evaluate the live series portion of this fellowship, which again is part 1. I will pause there. I think there might be some questions. So I'm not sure if Jill Mill or Laura, if you could share if we've been receiving any questions, that would be great.
Yeah,
Go ahead, Jimel.
So there was a question on if we finish before 8 July, can we submit it earlier?
Yes, you can submit it as soon as it's ready. And just to note that you will receive a confirmation email that your submission has been processed. And like I said, we will be reviewing, we have a team of mentors and experts that will be reviewing all proposals and providing feedback. And we will be selecting a certain number of proposals based on their strength in order to proceed to the next portion of the fellowship, which is that mentorship portion. Mentorship is not required, so we do ask that question on the proposal. But if you would like to be matched with a mentor, please indicate that. And again, based on availability and just your proposal itself, we'll be selecting a group to move on to the next stage. Other questions?
Yeah, so questions about getting the link to submit the proposal.
Yes, so we've circulated the link through the chat box. Again, after the session today, we'll be sending out an email again with that submission link. We'll also post the link to the Boost Learning Group as well as the Telegram channel. So you'll be able to access it on multiple platforms, wherever it's easiest for you to connect.
And
Yes.
Go ahead, Jimel.
So there was a question on the upper and lower limit for the proposals.
Yes, so there is a word limit for each section, which is clearly outlined on the in the online portal. You will not actually be able to go over that word limit. So just be sure to be mindful of how many words are indicated for each session.
And in terms of a lower word limit, I mean, the less you write, then the less likely it will be to be comprehensively addressing what we're hoping to achieve. So make sure to provide succinct information. And we also have a question about, is it possible to submit multiple projects?
Great, and as I indicated before, we're asking that each person only submit one proposal. If you choose to work with a team, we ask that you submit one proposal per team and that you select a focal point from your team to submit that proposal.
Okay.
I know we have a few more minutes. Any other questions?
Somebody's asked about what about the budget?
Sure, so the budget is a section on the template. Again, we circulated the template a couple weeks ago, so there shouldn't be any surprises on the questions that we've been asking. It just mirrors the same template that we shared via Microsoft Word document. So you'll see that section in the online template. We also have a few guiding questions, so be sure to answer them in your submission.
And people are asking about, is there any pre-made format for the proposal? So the template is already pre-prepared. You should have received that. But there's a couple of questions about the certification. What is the requirements for certification for this fellowship?
Sure. So in order to get a certificate of completion, again, you must have attended all of the live sessions, filled out those post-session surveys, and then you must submit your proposal or case study.
So there was also a question relating to the duration of the study or proposal that you put in.
Sure. And I'm not sure if either Jamil or Lara, you want to take that question.
So ideally, the duration should be till the end of the year, because that's how we have organized the mentoring. So the idea is that you put in a proposal from almost starting in a month's time and going till the end of the year, so that you can get some support from mentors and some support and advice as you're implementing. But we do realize that things take time to get approvals and get started at the country level. So it might extend a little bit to the next year. But ideally, it should be till the end of the year. Laura, do you think that
Yes.
is?
Yeah, that's correct. Thanks, Jamil. I think they should be trying to work with implementation of activities over the next couple of months towards the end of the year. And just one other thing is that somebody's asked a question, you know, if photos and figures reflect word count, they don't. Word counts are word counts. If you want to add photos or figures, there's a section at the end that allows you to add additional information.
Great. So I know that we're just about at time. I know that there are a lot other questions that are coming in. We will be sure to compile all of these and provide some written responses, but I'm mindful of everyone's time. So I think I might go ahead and close. Again, I want to thank our session facilitators from today. I also just want to thank all of our participants for making it through this 2-month live engagement series. We're really excited that you all stuck with us, and we're very much looking forward to reading through your strategic proposals and case studies. Anything from Jamil or Lara that you want to add?
I would just say, really encourage people to submit their plans. It's a great opportunity to get your ideas reviewed by experts. And so even if there was a question on, like, if I missed some sessions because of time conflict, can I still get a certificate? So don't worry about, you know, even if you miss some sessions and maybe you would not qualify for a certificate, but still submit your project. That's the most important. And you might still be, if the proposal is good, we would still consider you for mentoring. So I would really encourage everyone, if you've learned some new things and have some ideas to improve COVID recovery at your country, at your level, wherever you're working in the country, please do submit proposals, and we have lined up a few experts to review the proposals. Thanks.
Thanks, Jamil. And just also wanted to note that we have a couple of upcoming Boost learning opportunities. So the two that are projected on the screen are both self-paced courses. One is on storytelling for change, which we've just shared information actually with this group in our community. We also have a self-paced course on the open WHO platform, Discover Your Leadership Moment, which is around adaptive leadership. So we definitely encourage you to take advantage of both of those learning opportunities through Boost. And sorry, Laura, did you have anything else that you'd like to add?
I'd just like to say a huge thank you to Boost for this, and also a huge thank you to all the participants and to all the facilitators. It's been a great 8 weeks, so thank you.
Great. Well, thank you, everyone. Again, excited to read through strategic proposals and case studies, and we hope to see you in the Boost community soon. Have a great day.